Tonight, when you close your eyes, your heart could be entering the most dangerous hours of the entire day, and you wouldn't even know it. Nearly half of fatal heart attacks and strokes in adults over 50 happen between 10 p.m. and 6 a.m., according to the American Heart Association. But here's the shocking part. Most of these deaths are not caused by rare disease or bad genetics. They are triggered by simple nighttime habits people repeat every single day, believing they're harmless. In the next few minutes, you'll discover 5 silent habits that turn sleep into a cardiovascular risk zone, and a step-by-step routine that could protect your heart starting tonight. If you're over 50, this is not optional information. This could literally save your life. After the age of 50, your cardiovascular system no longer responds to stress the way it did in your 30s or 40s, and one of the most underestimated stressors is eating a late, heavy dinner. When you consume a large meal after 8 or 9 p.m., especially one high in saturated fats, refined carbohydrates, and sodium, your body is forced into a state of metabolic activation at the exact time it should be preparing for physiological recovery. Digestion is not a passive process. It requires significant blood flow to the stomach, pancreas, liver, and intestines. This increased demand means your heart must pump harder and faster to redistribute circulation toward the digestive tract, which directly opposes the natural nighttime decline in heart rate and blood pressure that should occur during sleep. Under normal circadian rhythm patterns, blood pressure drops by 10–20% at night, a phenomenon known as nocturnal dipping. This dipping phase allows the vascular system to rest and repair. However, a heavy evening meal interferes with this protective mechanism. Instead of dipping, blood pressure may remain elevated or even rise. In adults over 50, whose arteries are often stiffer due to age-related endothelial dysfunction and plaque buildup, this extra pressure significantly increases shear stress on arterial walls. Over time, this stress can destabilize fatty plaques inside coronary or carotid arteries, making them more prone to rupture during sleep. Late meals also affect blood chemistry. Large portions, particularly those rich in fats and simple carbohydrates, elevate triglyceride levels for several hours. Elevated nighttime triglycerides promote inflammation inside blood vessels and impair endothelial function. Research published in the European Heart Journal by the European Society of Cardiology has shown that individuals who regularly eat late dinners face a significantly higher risk of nocturnal heart attacks and strokes compared to those who eat earlier in the evening. The mechanism is multifactorial: impaired glucose tolerance at night, prolonged postprandial lipemia, and sympathetic nervous system activation all combine to create a prothrombotic environment. Another overlooked consequence of late heavy eating is acid reflux. When you lie down with a full stomach, gastric contents can move upward into the esophagus. This is not merely uncomfortable. Reflux can stimulate the vagus nerve, which plays a central role in heart rhythm regulation. In susceptible individuals, especially older adults with underlying cardiac conditions, vagal stimulation may trigger arrhythmias. An irregular heartbeat during sleep can reduce cardiac output or, in severe cases, precipitate more serious rhythm disturbances. Insulin sensitivity is also lower in the evening. This means your body handles glucose less efficiently at night, leading to higher and more prolonged blood sugar spikes. Elevated glucose contributes to oxidative stress and vascular inflammation, compounding cardiovascular risk. Additionally, late digestion increases core body temperature, which can fragment sleep architecture and reduce deep restorative sleep stages. Poor sleep quality itself is an independent risk factor for hypertension, arrhythmias, and stroke. When these physiological stressors occur night after night, the cumulative burden on the heart becomes substantial. Instead of entering a reparative state, your cardiovascular system remains in a low-grade activated state for hours. Over months and years, this pattern can accelerate atherosclerosis progression and increase the likelihood of a catastrophic nocturnal event. Shifting dinner to earlier in the evening and choosing lighter, easily digestible foods allows the body to complete digestion before sleep, restores normal nocturnal blood pressure dipping, reduces inflammatory markers, and significantly decreases nighttime cardiovascular strain. After the age of 50, blood pressure regulation becomes more fragile due to arterial stiffening, reduced baroreceptor sensitivity, and progressive endothelial dysfunction. This makes medication timing critically important, not optional. Many people assume that as long as they take their blood pressure, cholesterol, or blood-thinning medications at some point during the day, the benefit remains the same. That assumption is dangerous. The cardiovascular system follows a circadian rhythm, meaning hormone release, vascular tone, platelet activity, and blood pressure fluctuate predictably over 24 hours. If medication timing does not align with this rhythm, protection may be significantly reduced during the most vulnerable hours of the night. In healthy individuals, blood pressure drops during sleep in what is known as nocturnal dipping. However, in many adults over 50, especially those with hypertension, this dipping either becomes blunted or disappears entirely. Some individuals even experience nocturnal hypertension, where blood pressure rises during sleep instead of falling. This pattern is strongly associated with increased risk of stroke, heart attack, kidney damage, and sudden cardiac death. Studies published in the Lancet have shown that properly timed antihypertensive therapy, particularly evening dosing in appropriate patients, can significantly reduce nighttime blood pressure and cut cardiovascular event risk nearly in half. When medications are skipped or taken inconsistently, blood pressure can spike unpredictably during sleep. These spikes increase mechanical stress on arterial plaques. Over time, cholesterol deposits within artery walls form fibrous caps. Sudden surges in pressure can rupture these caps, exposing thrombogenic material to circulating blood. This triggers clot formation. If the clot blocks a coronary artery, a myocardial infarction occurs. If it blocks a cerebral artery, the result is an ischemic stroke. Because this process can happen silently during sleep, many patients never experience warning symptoms before a catastrophic event. Medication timing also affects platelet activity. Platelets become more active in the early morning hours, increasing clotting tendency. If blood-thinning medications are not present at adequate levels during this window, clot formation risk rises. Similarly, cholesterol synthesis in the liver is more active at night, which is why certain statins are more effective when taken in the evening. Taking them randomly or skipping doses reduces their ability to suppress overnight cholesterol production, indirectly increasing plaque progression over time. Another factor is medication half-life. Many antihypertensive drugs are designed to provide 24-hour coverage when taken consistently. Missing even one dose can create a gap in therapeutic coverage, allowing blood pressure to rebound. Rebound hypertension during sleep is particularly dangerous because the body is less equipped to compensate. Sympathetic nervous system fluctuations, changes in breathing patterns, and positional shifts can amplify pressure variability. This variability itself is an independent predictor of stroke. Inconsistent medication use also destabilizes long-term control. The vascular system adapts to steady regulation, but erratic dosing produces fluctuations in vascular tone. These fluctuations damage the endothelium, the delicate inner lining of blood vessels responsible for regulating dilation and clot prevention. Over time, endothelial injury promotes inflammation and accelerates atherosclerosis. For adults over 50, medication timing should be individualized under physician guidance, but consistency is non-negotiable. Setting fixed daily reminders, linking medication intake to established evening routines, and understanding the purpose of each drug dramatically improves adherence. Proper timing ensures that blood pressure remains controlled during the vulnerable nighttime window, platelet activity is moderated, cholesterol production is suppressed, and arterial plaques remain stable. Skipping or mistiming medication does not merely reduce effectiveness, it can remove the protective barrier that stands between stable sleep and a life-altering cardiovascular event. Sleep apnea is one of the most underdiagnosed yet physiologically destructive conditions affecting adults over 50, particularly when it remains untreated. The most common form, obstructive sleep apnea, occurs when the muscles of the throat relax repeatedly during sleep, causing partial or complete airway collapse. Each collapse leads to a pause in breathing that can last 10 to 30 seconds or longer. These pauses may occur dozens or even hundreds of times per night. What makes sleep apnea especially dangerous is that the person often has no memory of these events, yet each episode places intense stress on the cardiovascular system. When breathing stops, oxygen levels in the blood begin to fall. The body interprets this drop as a threat to survival. In response, it activates the sympathetic nervous system, triggering a surge of stress hormones such as adrenaline and cortisol. Heart rate accelerates, blood pressure spikes abruptly, and blood vessels constrict. This emergency response is designed for short-term danger, not repeated activation throughout the night. In untreated sleep apnea, this cycle of oxygen deprivation and stress activation can occur hundreds of times in a single sleep period, preventing the cardiovascular system from entering restorative mode. Repeated oxygen drops cause oxidative stress and inflammation inside blood vessels. The inner lining of the arteries, known as the endothelium, becomes dysfunctional. Endothelial dysfunction impairs the vessel's ability to dilate properly and promotes plaque formation. Over time, this accelerates atherosclerosis. Studies from major academic centers have consistently shown that untreated sleep apnea significantly increases the risk of hypertension, coronary artery disease, atrial fibrillation, heart failure, stroke, and sudden cardiac death. Large cohort analyses demonstrate that individuals with untreated moderate to severe sleep apnea have roughly triple the risk of nighttime heart attacks and up to 4 times the risk of stroke compared to those without the condition. Another dangerous mechanism involves blood pressure variability. Instead of the normal nocturnal dipping pattern, individuals with sleep apnea often experience repeated pressure surges throughout the night. This pattern, known as non-dipping or reverse dipping, is strongly associated with stroke risk. The repeated spikes increase mechanical stress on arterial plaques, making rupture more likely during sleep. In addition, low oxygen levels increase blood viscosity and promote clotting tendencies, further elevating ischemic risk. Cardiac rhythm disturbances are also common. Fluctuating oxygen levels and surges of sympathetic activity destabilize the electrical conduction system of the heart. Atrial fibrillation, bradyarrhythmias, and ventricular arrhythmias occur more frequently in patients with untreated sleep apnea. For someone with pre-existing coronary artery disease, these rhythm disruptions can become life-threatening during the quiet hours of the night. Warning signs often go ignored. Loud chronic snoring, witnessed breathing pauses, gasping or choking during sleep, morning headaches, dry mouth upon waking, excessive daytime sleepiness, difficulty concentrating, and blood pressure that remains difficult to control despite medication are all red flags. Many individuals dismiss snoring as merely inconvenient, but persistent loud snoring combined with fatigue is a clinical signal that warrants evaluation. Diagnosis typically involves a sleep study, either in a laboratory or through validated home testing. Treatment, most commonly continuous positive airway pressure therapy, stabilizes the airway, prevents oxygen drops, and restores normal nighttime cardiovascular patterns. When effectively treated, blood pressure often improves, arrhythmia frequency decreases, inflammatory markers decline, and overall cardiovascular risk is significantly reduced. Ignoring sleep apnea allows silent nightly damage to accumulate, transforming sleep from a restorative state into a prolonged period of cardiovascular strain that substantially increases the likelihood of a catastrophic event. Going to bed dehydrated may seem harmless, especially for adults over 50 who deliberately reduce evening fluid intake to avoid nighttime trips to the bathroom, but physiologically it creates a high-risk internal environment during the most vulnerable hours of the night. Aging alters fluid regulation in several ways. Total body water decreases with age, kidney concentrating ability declines, and the sensation of thirst becomes blunted. As a result, many older adults operate in a state of mild chronic dehydration without realizing it. When this dehydration continues into the nighttime period, cardiovascular risk increases significantly. Water is a primary determinant of blood volume. When fluid intake is inadequate, plasma volume decreases. As plasma volume drops, blood becomes more concentrated. This increase in hematocrit and plasma osmolality makes the blood more viscous. Thicker blood flows more slowly through arteries and small vessels, especially in areas already narrowed by atherosclerotic plaque. Sluggish flow promotes clot formation because platelets and clotting factors remain in contact with vessel walls for longer periods. During sleep, when heart rate naturally slows and blood pressure dips, circulation already becomes less forceful. If blood viscosity is simultaneously elevated, perfusion to critical organs such as the heart and brain may become compromised. Dehydration also activates compensatory hormonal systems. The body releases antidiuretic hormone and stimulates the renin-angiotensin-aldosterone system to conserve fluid. Activation of this system causes vasoconstriction, increasing vascular resistance. In someone with stiffened arteries or underlying coronary disease, even modest increases in vascular resistance can elevate cardiac workload. Instead of resting, the heart must pump against tighter vessels, increasing myocardial oxygen demand at a time when oxygen delivery may already be reduced. Electrolyte balance is another factor. Inadequate hydration can alter sodium and potassium concentrations, which influence cardiac electrical stability. Even subtle electrolyte shifts may increase susceptibility to arrhythmias in vulnerable individuals. When combined with the natural changes in autonomic tone that occur during sleep, dehydration-related electrolyte imbalance can destabilize cardiac rhythm. Evidence supports this physiological link. Research published in the Journal of Cardiovascular Disease has shown that moderate dehydration significantly increases the incidence of nocturnal cardiovascular events. Observational data consistently demonstrate higher rates of ischemic stroke during early morning hours, a period when dehydration from overnight fluid loss is most pronounced. During sleep, fluid is continuously lost through respiration and perspiration. By early morning, blood viscosity may be at its peak. If a person begins the night already dehydrated, this overnight fluid loss compounds the problem, creating a prothrombotic state by dawn. Another overlooked consequence is reduced cerebral perfusion. The brain relies on stable blood flow to maintain oxygen delivery. Increased viscosity and reduced plasma volume impair microcirculatory flow in cerebral vessels. In individuals with narrowed carotid arteries or small vessel disease, this can precipitate ischemia. Many early morning strokes occur during or immediately after sleep, when dehydration-related hemoconcentration is greatest. The solution is physiologically simple but clinically meaningful. Consuming a moderate amount of water 1 to 2 hours before bedtime supports adequate plasma volume without excessively disrupting sleep. Using the bathroom immediately before lying down minimizes nocturnal awakenings. Keeping water nearby allows small sips if thirst occurs. Adequate hydration maintains optimal blood viscosity, supports stable blood pressure regulation, reduces clot formation risk, and allows the cardiovascular system to enter true restorative mode during sleep rather than functioning under avoidable circulatory strain. Bedroom temperature is not merely a comfort preference. It directly influences cardiovascular workload, vascular tone, autonomic balance, and sleep architecture, all of which are critically important after the age of 50. As people age, thermoregulation becomes less efficient. The body's ability to dissipate heat or conserve warmth declines due to reduced sweat gland activity, impaired vasodilation responses, and diminished autonomic flexibility. Because of this reduced adaptability, older adults are more vulnerable to environmental temperature extremes during sleep, when physiological defenses are already altered. When a bedroom is too warm, typically above 24 degrees, 75 degrees, the body must actively attempt to release excess heat to maintain core temperature. This process involves peripheral vasodilation, meaning blood vessels near the skin widen to increase heat loss. Vasodilation initially lowers vascular resistance, but it also requires the heart to increase output to maintain adequate circulation. Heart rate may rise subtly, and cardiac workload increases. Additionally, Warmer environments promote fluid loss through perspiration, even if sweating is not noticeable. Overnight fluid depletion can contribute to hemoconcentration, increasing blood viscosity and compounding cardiovascular strain. Studies from institutions including Harvard University have linked excessively warm sleeping environments with poorer sleep efficiency, elevated nighttime heart rate, and increased cardiovascular stress markers. Heat also disrupts sleep stages. Deep, non-rapid eye movement sleep is when blood pressure naturally dips and the cardiovascular system enters repair mode. Elevated room temperature fragments sleep and reduces time spent in restorative stages. When sleep becomes shallow and interrupted, sympathetic nervous system activity remains higher than normal. Instead of sustained parasympathetic dominance, which protects the heart, the body cycles between microarousals and stress activation. Over months or years, this pattern contributes to sustained hypertension and increased arrhythmia risk. On the other extreme, sleeping in a room that is too cold also places significant strain on the cardiovascular system. Cold exposure triggers peripheral vasoconstriction, narrowing blood vessels to preserve core body heat. Vasoconstriction increases systemic vascular resistance, meaning the heart must pump against greater pressure. For individuals with already stiff arteries or underlying coronary artery disease, this increased afterload can be dangerous. Elevated vascular resistance raises blood pressure, increases myocardial oxygen demand, and may destabilize vulnerable atherosclerotic plaques. Epidemiological data across Europe consistently show spikes in nighttime heart attacks and strokes during cold weather periods, particularly among older adults. Cold environments can also activate the sympathetic nervous system. Stress hormones rise, heart rate variability decreases, and blood pressure fluctuations become more pronounced. In individuals prone to nocturnal hypertension, cold-induced vasoconstriction may eliminate normal dipping patterns entirely. Furthermore, abrupt temperature changes when getting out of bed during the night can trigger sudden blood pressure shifts, increasing fall risk and cardiovascular instability. The optimal sleeping temperature range for cardiovascular stability is generally between 18 to 22 degrees Celsius, 65 to 70 degrees. Within this range, thermoregulation requires minimal compensatory effort. Blood vessels maintain balanced tone, heart rate remains stable, and deep sleep stages are preserved. Maintaining consistent temperature is equally important, as rapid fluctuations can provoke autonomic responses. Environmental control should be considered a preventive cardiovascular measure rather than a luxury. Using climate control systems, appropriate bedding, layered blankets, or breathable fabrics can help maintain thermal neutrality. Monitoring bedroom temperature with a simple thermometer ensures accuracy rather than relying on subjective perception. By stabilizing the sleep environment, the cardiovascular system is allowed to enter true restorative mode, minimizing unnecessary stress and reducing the probability of nighttime blood pressure surges, arrhythmias, or ischemic events.